right, we're going to slow things down a little bit because this is our last video in our RSV series. Okay, so you've assessed our sick infant from the urgent care with RSV secondary to bronchiolitis, and you've provided the appropriate interventions. You've properly secured your patient, and now you're transporting to a children's hospital. What do we want to do now? We want to reassess. And what are we looking for? We're looking for improvement. In what? Well, that is a great question. So patients with bronchiolitis secondary to RSV can present with a number of symptoms and conditions that we can correct or resolve. And this includes hypoxemia, fever, dehydration, respiratory distress, and/or respiratory failure. Now, what's the difference between respiratory distress and respiratory failure? In respiratory distress, compensatory mechanisms are allowing the patient to continue to maintain perfusion. In respiratory failure, perfusion is not being maintained despite compensatory measures. And the two primary compensatory measures in infants and young children that we can easily identify are increased heart rate and increased respiratory rate. We can also observe an increased effort by way of retractions, grunting, paradoxical breathing, or seesaw breathing. But the means of identifying respiratory failure are through PaO2 and PaCO2. These values are routinely measured in critical care and clinical environments, but not customarily in 911. The thresholds for failure would be below 60 millimeters of mercury for PaO2 and above 45 millimeters of mercury for PaCO2. SpO2 can be a good surrogate for PaO2 by remembering the 4, 5, 6, 7, 8, 9 rule, where 90% SpO2 roughly correlates to 60 millimeters of mercury PaO2. So an SpO of less than 90 would indicate respiratory failure. However, while EtCO2 can be a valuable tool that can provide a lot of good information in sick patients, both young and old, it's not a great surrogate for PaCO2 for our sick kid, as bronchiolitis secondary to RSV prohibits good perfusion and not as much CO2 gets out. So what you're measuring and observing through end tidal isn't telling the real story of what's happening beyond the lungs. And if it is over 45 millimeters of mercury, then you're probably way behind the curve. If you can measure these arterial or venous values, we want to see a return or a trend towards normal parameters. And regardless of whether you can measure these values, we want to see resolution of the indicators that they're in failure. And not just vital signs. We want to see cyanosis clear. We want to see capillary refill time improve. We want to see tachypnea and tachycardia reduced, improved respiratory effort, and improved in alertness and cognition. And I'm going to leave you with two things to keep in mind during a reassessment. Number one, when dry respiratory kids are rehydrated and previously dry secretions become mobilized, it may appear as though they've gotten a little worse. Don't panic. This is usually transient. And number two, these kids didn't get real sick in 20 minutes, and they aren't going to get symptom-free in 20 minutes. The goal is to make steady progress, not to achieve instant homeostasis.